So I'm going to give you an update on the approved TKIs. You heard a nice talk from Rick about venetoclax, which is now approved for deletion 17p relapse patients. So I'm going to focus on a little bit of an update on Ibrutinib and Idelalisib. So let's start with BTK inhibition. So this is the follow-up of the initial study in CLL. Remember, we had the first-in-man study with Ibrutinib, and the very next study done was this study, the 1102 study for patients with CLL. And as the study got underway, a treatment-naive cohort was added. So this represents the longest follow-up we have of treatment-naive patients as well as relapse patients. So I presented this at the AACR last year, and it's focusing on the approved dose, the 420 milligram dose that we use for our patients. Here's the study design. So of the 31 treatment-naive patients, 27 had the approved dose, and then you see the relapse refractory group as well. The median time on study at the time this was reported is 32 months. I have several patients who continue on for more than 6 years now. So here's an update of the patient disposition. You could see that the majority of patients in the treatment-naive group, 81%, remain on treatment, as do the majority of the relapse refractory patients. And just to remind you, these weren't just ordinary relapse patients. This isn't somebody who had FCR and 5 years later needed treatment again. This was really the worst of the worst. These are patients who were, by definition, had to have early progression after a purine analog-containing regimen, and many of them had many lines of therapy. Really, for some, it really was a life-saving intervention because they had run out of options. And you can see the primary reasons for discontinuation here. And I think this reflects the overall clinical experience with one exception, and that is, I think in overall clinical experience, we're seeing more patients discontinuing for adverse events than perhaps we reported in the trials. Largely issues, I think, related to quality of life, perhaps arthralgias, fatigue, etc. In terms of safety, I think one of the issues that comes up is how do patients do as they stay on therapy for long periods of time, for many years. And so it's very helpful to follow this cohort long term, even though it is small. You can see that the time of onset is generally early. The side effects that we're aware of, neutropenia in some patients, usually when they have active disease and you're just starting therapy. Diarrhea can be something you see when you first start patients, as well as rash, but generally does not preclude continuing to dose the patients. One exception, though, is hypertension. I think we've realized that as time goes on, we do see this as probably a drug-related side effect, so it's something to keep an eye on if you have patients who remain on Ibrutinib long-term. Now, you've seen this in several of the other speakers' talks. This is the progression-free survival. The upper curve is the treatment-naive patients. And as Rick pointed out, one patient progressed at 8 months with Richter's transformation. I believe there may have been a second patient who's subsequently progressed after this analysis, but no other patient has progressed. And as I mentioned, I have several who have been followed, that I've followed now for more than 6 years on therapy. And even in the treatment, the relapse refractory, this heavily pretreated population, you can see that the 30-month progression-free survival here is 75%. Very impressive, I think. And similarly for overall survival. When you look at outcomes stratified by cytogenetic abnormalities, the deletion 17p patients do quite well. Certainly something we're all familiar with now, and certainly this is led to the approval of Ibrutinib for this indication. The median progression-free survival has been reached for that subgroup in this study at about 32 months, which is quite impressive. You'll see an update, I think, at ASH about the 11q, but for the study as a whole in the relapse refractory group, the median progression-free survival is still not yet reached, even in this study that was started many years ago. Of course, we then went on and had the pivotal randomized study, RESONATE-2. This was compared to chlorambucil as initial therapy. This is treatment naive, over 65. If you were between 65 and 70, you were only eligible if it was felt that you had a comorbidity that precluded the use of FCR. And importantly, it did exclude deletion 17p patients. So we don't have upfront data from this trial regarding 17p patients. So randomization between Ibrutinib and chlorambucil. Primary outcome, progression-free survival, quite a distinct difference here as one might expect. I don't think that this comes as a big surprise to anyone that Ibrutinib was superior. And in terms of overall survival, you can see the results here as well. We did a subsequent analysis, a statistical analysis to try to control for the crossover because, as you may recall, patients who received chlorambucil and either didn't respond or later progressed were able to cross over to Ibrutinib. And there's an abstract in your program that looks at that analysis with an additional 10 months follow-up from this report, and the results hold up in terms of the benefit of initial Ibrutinib therapy. So in many ways, it argues for not sequencing therapies, not holding back Ibrutinib for later, but instead using it as initial treatment compared to chlorambucil. Now, I don't think that this study showing improved progression-free survival is really the major contribution of this particular trial. I mean, chlorambucil, who really cares about that as a comparator? I think the important part of the study is shown in this slide, and that is how do patients do if they receive Ibrutinib and progress? You heard a comment about that in one of the earlier talks, the comment that patients do poorly. And I think what we have to keep in mind is those studies involve relapse refractory patients, patients from the early Ibrutinib trials, patients who were very, very heavily pretreated. And so when they did progress, it's not surprising that they didn't have any other options for treatment. And so many of them died quite early, within a matter of months. I think that's very, very different than using the drug earlier, using the drug up front, or even for typical first relapse patients. So I think as we follow along, it'll be very important to see from this study what happens over time. So 12 patients discontinued due to adverse events. This is with a median follow-up of 18 months. 11 of these patients are alive. One died of an infectious complication, pneumonia. 3 progressed within 6 months after discontinuation. 1 started BR 8 months later, and 2 remained without any subsequent therapy. 3 started subsequent therapy, 2 with FCR, 1 with chlorambucil, within 8 months after discontinuation, and 5 were progression-free without subsequent therapy. Now, only 2 patients so far have been reported who stopped treatment because of progression, and both of those patients had not yet received any subsequent therapy. So I think, as I mentioned, it'll be very important to look for this as we report longer follow-up. How do these patients do who remain on Ibrutinib when they received it for their initial treatment? Safety results from this trial are very similar to what we've seen in the earlier trials and what I alluded to in the initial study. Hypertension, atrial fibrillation, very consistent with the initial RESONATE trial, about 6 or 7%, something that you typically see within the first year. You can see bleeding events. Easy bruising isn't uncommon, but major bleeding, fortunately, remains uncommon. So let's turn to our other pathway, and that's PI3 kinase delta inhibition. And as you likely know, the PI3 kinase plays a central role in many of the signaling pathways within the B cell, including the malignant B cell, and really modulates a lot of the pathways that are important for the advantages the leukemic cell has, for example, proliferation, inhibition of apoptosis, et cetera. So it's a natural target to try to inhibit in order to have a therapeutic benefit. So, of course, we have a drug, an approved drug, Idelalisib, a PI3 kinase delta inhibitor. But there have been some recent data issues, safety issues that have come up. So in 2016, we can ask a number of questions. Is it an efficacious drug? Is it a safe drug? And when should you consider using Idelalisib? This study represents actually the longest follow-up reported to date of the pivotal study that led to its approval. The study in patients who were considered unfit for chemoimmunotherapy, who were randomized to rituximab plus placebo versus rituximab plus Idelalisib. That initial study was published in the New England Journal. It was a positive study, both in terms of progression-free survival and overall survival, in favor of the addition of Idelalisib. The results of this study were based on the second interim analysis, and here we have longer follow-up. The first study, the median follow-up was only about 6 months. So here you can see that the differences, of course, hold up. The median progression-free survival with the addition of Idelalisib was 19 months versus 7 months. As I mentioned, there was also an overall survival advantage. But still, even with that report, the follow-up on that initial study was relatively short, and I think it really underreports some of the safety issues, some of the toxicities that we see in using the drug and that we're now aware of. So we tried to quantify this and did an analysis of most of the early clinical trials with Idelalisib, including the pivotal study. Here's a summary of the common adverse events that are seen. Diarrhea or colitis in 37%, any grade. Only 11% here, grade 3 with monotherapy. But remember, grade 2 diarrhea is quite significant. So we shouldn't just focus on grade 3. And with combination therapies in the trials, we see similar results. Infection is something we see, not surprisingly, in patients with CLL or patients especially who are heavily pretreated. And then, of course, we see a transaminitis. This is something we observed early in the studies. And here's a summary, up to 50% of any grade and 16% at least grade 3. But early on, we recognize this. It's an early event within the first usually 8 weeks. We hold the drug. It resolves. You restart the drug. And it generally didn't lead to having to discontinue therapy. In terms of onset of the diarrhea or colitis, you can see in summary of these studies, the median onset was 7 months. This is not something, this colitis, which seems to be an on-target effect of the delta inhibition, is not something you typically see during the first month or 2 of treatment, but it's later, and it can be much later. It can be a year later. It can be 2 years later. So it's really led to difficulty in keeping patients on therapy continuously. Pneumonitis is an uncommon but well-recognized side effect as well, seen in only a few percentage of patients, and that tends to be an early onset side effect. So that's sort of where things were until earlier this year when we learned from several ongoing studies, very important studies in both previously treated patients with low-grade lymphomas and previously untreated patients, that there was further problems, and that is a difference in mortality. So in these randomized trials, there was a significant difference in mortality in the Idelalisib containing arms, and that led to the discontinuation. Patients were taken off drug of many of these studies, including all of the studies where it was being used for previously untreated patients. Now there's, as a result of further analysis of these studies, there's new safety label indication, and that you'll see if you look up the package insert that gives you guidance as far as using pneumocystis prophylaxis and being aware of other infectious complications that may arise. So the other important issue, though, is something that really only came out based on data from Jennifer Brown's group at the Dana-Farber. This was a presentation that their group gave at ASH this past year. This was a study where Idelalisib was used for previously untreated patients, but the important distinction here is that for the first time, it was being used in younger patients. Patients under the age of 65, previously untreated. We had never had that experience in any of our prior trials, and you can see here that there was a very significant number of patients who experienced transaminitis, and not just the transaminitis that I talked about previously, but actually very severe transaminitis, grade 3 and 4 in many of these patients. So 13% grade 4, 21% grade 3 here. In total, over time, half the patients had at least a grade 3 transaminitis. You can see the time to onset here of the hepatotoxicity. Not particularly long follow-up yet in this study. So here's the colitis, but even here you can see it. And then the pneumonitis in one patient as an early side effect. So they looked at a number of risk factors. They found that age was a risk factor for early hepatotoxicity, as I mentioned. Younger patients tended to have more severe hepatotoxicity. We're finally starting to understand the mechanisms behind this, or at least the likely mechanisms, and it seems to be immune-mediated. You see a lymphocytic infiltrate on liver biopsies. You see a lymphocytic colitis in patients who receive Idelalisib. Typically, we can manage these patients, treat them with corticosteroids, but in some cases, in several of her patients with severe hepatotoxicity, even steroids seem to be insufficient. But unfortunately, one often sees a rapid recurrence upon re-exposure to the drug, especially with the hepatotoxicity. There's preclinical data that supports this mechanism from mouse models, and importantly, they've demonstrated a decrease in regulatory T cells, Tregs, in patients treated with Idelalisib. So for example, when you look at the mouse knockout model of PI3 kinase delta, these mice develop an autoimmune colitis. When you look at mutations that disrupt Treg function, both in mice and humans, you get autoimmune syndromes like hepatitis or pneumonitis. And when you look at these knockout mice, you do see decreased numbers of regulatory T cells. In their study, you can see here quite nicely that by day 28, there's a decrease in regulatory T cells as patients remain on drugs. So to answer our original questions, yes, Idelalisib is a very efficacious drug, but its use is limited by significant toxicities. We should be aware of them, and particularly in younger, less heavily pretreated patients. It should not be used as frontline therapy. That's clearly indicated in the label now, and I don't think it will be developed in the future as frontline therapy. You saw some nice flow diagrams from Dr. Chesson with treatment algorithms, and at least in the relapse setting, Idelalisib plus rituximab is a choice for all of our patients, but I think it has to be a very considered choice. You have to put it in the context of other therapies that the patients may have available to them, and make a decision based on your individual patient. Thank you.